Hello and welcome. This video is the second in the series of videos with ESHRE guidance on the treatment of endometriosis. This video contains two chapters, diagnosis of endometriosis and pain management. These will be followed by more videos on the ESHRE guidance with focus on endometriosis and adolescence, fertility, cancer, and menopause. The goal of these videos is to increase the understanding of current evidence regarding evidence-based management of endometriosis. The ESHRE guidelines on endometriosis has been published before in 2005 and 2014, and this is now the third update of the guidelines. The guideline development group recommends that clinicians should consider the diagnosis of endometriosis in individuals presenting with the following cyclical and non-cyclical signs and symptoms. And these symptoms are suggestive of endometriosis. And these symptoms include dysmenorrhea, deep dyspareunia, dysuria, dyschezia, painful rectal bleeding, or hematuria, shoulder tip pain, catamenial pneumothorax, cyclical cough, hemoptysis, chest pain, cyclical scar, swelling and pain, fatigue, and infertility. Catamenial pneumothorax is defined as recurrent spontaneous pneumothorax occurring within 72 hours before or after the onset of menstruation. Historically, it was believed to be a rare syndrome and was attributed to intrathoracic endometriosis. So as you can well imagine that there is a huge number of symptoms which can be associated with endometriosis, and the guideline group recommends as a good practice point that clinicians should consider the diagnosis of endometriosis in any woman who is complaining of any of these symptoms. Another guideline development group statement states that although currently no evidence exists that a symptom diary or a questionnaire or an app reduces the time to diagnosis or leads to an earlier diagnosis, even though this is true, the guideline group considers their potential benefit in complementing the traditional history-taking process as it aids in objectifying pain and empowering women to demonstrate their symptoms. This means that if you have a patient who has any of the symptoms which was documented in the earlier statement by this group, then you can ask that woman to keep a symptom diary. That means that on a daily basis, she records her symptoms, and she also records the day of the start of her period and the day of the end of her period. And this gives the woman herself an objective assessment of her pain and the association of her pain with her periods. So even though there is no evidence to say that this is helpful and makes diagnosis earlier, but they recommend that this should be kept. Moving on, we find in chapter 1 recommendations from the group regarding clinical examination and diagnostic tests. The clinical examination, including vaginal examination where appropriate, should be considered to identify deep nodules or endometriosis in patients with suspected endometriosis, although the diagnostic accuracy is low. And this is a strong recommendation. In women with suspected endometriosis, further diagnostic steps, including imaging, should be considered even if the clinical examination is normal. So by imaging here, we mean ultrasound examination. So ultrasound examination is helpful in telling us if there is any involvement of the ovary or if there are any nodules that are visible around the uterus, especially in the pouch of Douglas. Again, this is a strong recommendation. So if any patient has pelvic pain, she should have a pelvic ultrasound, preferably transvaginally if it is possible. Clinicians should not use measurement of biomarkers in endometrial tissue, in blood, in menstrual or uterine fluids to diagnose endometriosis. Generally, clinicians will get a CA125 test done, and this is supposed to be helpful in the diagnosis. But according to the recommendation, the guideline group suggests that they should not use measurement of biomarkers. Again, this is a strong recommendation. Clinicians are recommended to use imaging, ultrasound, or MRI in the diagnostic workup for endometriosis, but they need to be aware that a negative finding does not exclude endometriosis, particularly superficial peritoneal disease. This is a strong recommendation. However, we should beware that MRI should not be done in every patient who complains of any kind of symptoms suggestive of endometriosis. Rather, we should start with ultrasound examination, and if there is any concern regarding the depth of the invasion of the disease, or if there is any concern that there is any cancerous changes in the tissue, then MRI or CT can be performed. But MRI certainly is not the first level examination or first level investigation that should be done for these patients. In patients with negative imaging results, or where empirical treatment was unsuccessful or inappropriate, the group recommends that clinicians consider offering laparoscopy for the diagnosis and treatment of suspected endometriosis. This is a good practice point suggested by the guideline group. And it means that if a patient has symptoms suggestive of endometriosis, and if you make a clinical diagnosis of endometriosis and the patient is started on treatment, empirical treatment with the progestogens, and she's been on treatment for a month or 2 months, and yet there is no difference in her symptoms, in the severity of her symptoms, then the guideline group recommends that you can consider offering laparoscopy for the diagnosis and for the treatment of the condition. So laparoscopy is not a first-line investigation, or it is not necessary for diagnostic purposes. Diagnosis can be done on clinical basis. The group further recommends that laparoscopic identification of endometriotic tissue is confirmed by histology. So in other words, if you do a laparoscopic examination of the pelvis and you take some tissue for biopsy, and the biopsy tissue comes back saying that there was no evidence of endometriosis, then it does not rule out the disease. The rationale for this is that it is impossible to identify tissue of where endometriosis is present for 2 reasons. One reason is that we know the appearance of endometriotic involved tissue in the pelvic peritoneum and in the pelvic organs, but we are not certain that we can identify all the lesions. And the second reason is that it is possible that we can miss the lesion on our laparoscopic examination. So on the basis of this, the group has issued a statement saying that both diagnostic laparoscopy and imaging combined with empirical treatment can be considered in women suspected of endometriosis. There is no evidence of superiority of either approach. Of pros and cons should be discussed with the patient. This means that there is no superiority of doing a laparoscopy over making a clinical diagnosis, or of imaging over a clinical diagnosis. So if you have made a diagnosis on the basis of clinical grounds and you have started treatment, this treatment will then be called empirical treatment. That means treatment on the basis of clinical examination or clinical assessment. And at this point in time, laparoscopy and imaging and empirical treatment have an equal status in terms of their reliability in starting the treatment. There is no superiority of either approach, and you have to discuss with the patient what she would like. Going further, we find in the same chapter 1 that follow-up and psychological support should be considered in women with confirmed endometriosis, particularly deep and ovarian endometriosis, although there is currently no evidence of benefit or regular long-term monitoring for early detection of recurrence, complications, or malignancy. This is a weak recommendation. The appropriate frequency and type of follow-up of monitoring is unknown and should be individualized based on previous and current treatments and severity of the disease and symptoms. This is a good practice point. Another overall statement which has been issued by the group with respect to clinical diagnosis says that although no adequate studies exist to support the benefit of early versus late diagnosis, the group recommends that in symptomatic women, an attempt should be made to relieve the symptoms either by empirical treatment or after a diagnosis of endometriosis. So a diagnosis of endometriosis means that you have done a laparoscopy or you have done a pelvic ultrasound followed by an MRI. Now we come to the second chapter of the guideline, which deals with treatment of endometriosis associated pain. So as far as analgesics is concerned, women may be offered non-steroidal anti-inflammatory drugs or NSAIDs, either alone or in combination with other treatments to reduce endometriosis associated pain. This group is usually used for treating arthritis, and these drugs can be obtained over the counter, and they include drugs such as aspirin, ibuprofen, and naproxen. It is recommended to offer hormone treatment, combined hormonal contraceptives, progestogens, GnRH agonists, or GnRH antagonists as one of the options to reduce endometriosis associated pain. This is a very strong recommendation based on very hard evidence that this works for patients. A good practice point recommends that the clinicians take a shared decision-making approach and take individual preferences, side effects, individual efficacy, costs, and availability into consideration when choosing the hormonal treatment for endometriosis-associated pain. The concept of shared decision-making is a very important one, and in evidence-based medicine, it holds value even in a court of law, as long as the patient is aware of what you are talking about and has given full consent in her own language. Combined hormonal contraceptives, either given orally or vaginally or transdermally to reduce endometriosis associated dyspareunia, dysmenorrhea, and non-menstrual pain, is highly recommended as a strong recommendation. Women suffering from endometriosis-associated dysmenorrhea can be offered the continuous use of a combined hormonal contraceptive pill. This is a weak recommendation, and generally speaking, women with very severe endometriosis will not respond to the combined hormonal contraceptive pill as the initiating treatment, but can be used for continuation of treatment. It is recommended to prescribe women progestogens to reduce endometriosis-associated pain. This is a strong recommendation. The group recommends that clinicians take the different side effect profiles of progestogens into account when prescribing them. It's a good practice point. It is recommended to prescribe women a levonorgestrel releasing intrauterine system or an etonorgestrel releasing subdermal implant to reduce endometriosis associated pain. This is a strong recommendation, and there is hard evidence to show that it works for patients. Moving on to GnRH agonists, it is recommended to prescribe women GnRH agonists to reduce endometriosis-associated pain, although evidence is limited regarding dosage or duration of treatment. This is a strong recommendation, and generally, treatment is not given beyond 3 to 4 months. The group also recommends that GnRH agonists are prescribed as a second line, for example, if hormonal contraceptives or progestogen has been ineffective due to their side effect profile. Clinicians should consider prescribing combined hormonal add-back therapy alongside GnRH agonist therapy to prevent bone loss and hypoestrogenic symptoms. This is a strong recommendation. As far as GnRH antagonists are concerned, it can be considered to describe women GnRH antagonists to reduce endometriosis-associated pain, although evidence is limited regarding dosage or duration of treatment. This is a weak recommendation based on weak evidence. The group recommends that GnRH antagonists are prescribed as second line, for example, if hormonal contraceptives or progestogens have been ineffective due to their side effect profile. As far as aromatase inhibitors are concerned, in women with endometriosis-associated pain refractory to other medical or surgical treatment, it is recommended to prescribe aromatase inhibitors as they reduce endometriosis-associated pain. Aromatase inhibitors may be prescribed in combination with oral contraceptives, progestogens, GnRH agonists, or GnRH antagonists. This is a strong recommendation. As part of the surgical treatment for managing endometriosis-associated pain, the group has issued a statement which says that it can be concluded that laparoscopic uterine nerve ablation, or LUNA, is not beneficial as an additional procedure to conventional laparoscopic surgery for endometriosis, as it offers no additional benefit over surgery alone. However, presacral neurectomy is beneficial for treatment of endometriosis-associated midline pain and as an adjunct to conventional laparoscopic surgery. But it should be stressed that presacral neurectomy requires a high degree of skill and is associated with an increased risk of adverse effects such as intraoperative bleeding and post-operative constipation, urinary urgency, and painless first stage of labor. Therefore, it should be done by a surgeon who has experience in performing pelvic laparoscopic surgery and who has trained for presacral neurectomy. But patients have to be counseled very carefully that they may get rid of the pain, but they may also have complications such as constipation, urgency, and if they consent to it, then only can you proceed. Due to the heterogeneity of patient populations, surgical approaches, preferences, and techniques, the guideline development group decided not to make any conclusions or any recommendations on the techniques to be applied for the treatment of pain associated with deep endometriosis. But there are some good practice points, and these are that if women have deep endometriosis, they should be referred to centers that are dealing with endometriosis and with its complications. And secondly, that if the patient is undergoing surgery, particularly for deep endometriosis, patients should be counseled and they should be informed of the potential risks of the surgery, the benefit of the surgery, the long-term effect on the quality of life. Clinicians can consider hysterectomy with or without removal of the ovaries, with the removal of all visible endometriotic lesions in those women who no longer wish to conceive and fail to respond to more conservative treatments. Women should be informed that having a hysterectomy may not necessarily cure the symptoms or the disease. This recommendation has weak evidence as a basis. The guideline group has also recommended when a decision is made whether to remove the ovaries, the long-term consequences of early menopause and possible need for hormone replacement therapy should be considered. The group recommends that when hysterectomy is performed, a total hysterectomy is preferred. There are currently no prognostic markers that can be used to select patients that would benefit from surgery. Such markers would need to be assessed prior to surgery and predict a clinically meaningful improvement of pain symptoms. Going further, we talk about medical treatment as an adjunct to surgery. This is again a continuation of Chapter 2 of the ESHRE Guidelines on Endometriosis 2022. Let's now talk about the group recommendation for medical therapies as an adjunct to surgery. It is not recommended to prescribe preoperative hormone treatment to improve the immediate outcome of surgery for pain in women with endometriosis. This is a strong recommendation. Another recommendation, which is not as strong, says that patients may be offered post-operative hormone treatment to improve the immediate outcome of surgery for pain in women with endometriosis if not desiring immediate pregnancy. The group recommends as a good practice point that clinicians take a shared decision-making approach and take individual preferences, side effects, individual efficacy, costs, and availability into consideration when choosing between hormone treatments and surgical treatments for endometriosis-associated pain. As far as non-medical management strategies are concerned, there is not strong evidence to support this, but these non-medical strategies are available in the form of Chinese medicine, nutritional treatment, electrotherapy, acupuncture, physiotherapy, exercise, and psychological interventions to reduce pain or improve the quality of life measures in women with endometriosis. These may have potential benefits, but we don't know if there is any harm. With this slide, we now move to chapter 4, which is the prevention of recurrence of endometriosis. The group has mentioned and recommended some strong recommendations for interventions that can prevent the recurrence of endometriosis. And these include when surgery is indicated in a woman with endometrioma, clinicians should perform ovarian cystectomy instead of drainage and electrocoagulation. This is a very important point and has been strongly recommended by the group. And they believe that by doing so, you can prevent the associated secondary symptoms of endometriosis associated dysmenorrhea, dyspareunia, pelvic pain. And at this time, when you are performing a cystectomy, you should make sure that you do not remove normal ovarian tissue, as the risk of reduced ovarian reserve is always present when you are removing tissue as compared as when you are electrocoagulating. Another strong recommendation by the group to ensure that recurrence of endometriosis does not take place is that clinicians should consider prescribing the post-operative use of a levonorgestrel releasing intrauterine system or a combined oral contraceptive treatment for at least 18 to 24 months for the secondary prevention of endometriosis associated dysmenorrhea. Another strong recommendation is that after surgical management of ovarian endometrioma in women not immediately seeking fertility or conception, clinicians are recommended to offer long-term hormonal treatment. This may be in the form of an intrauterine system releasing levonorgestrel or combined hormonal contraceptives for the secondary prevention of endometrioma and endometriosis associated related symptom recurrence. A weak recommendation by this group is that for the prevention of recurrence of deep endometriosis and associated symptoms, long-term administration of post-operative hormonal treatment such as progestogen treatment can also be considered. So clinicians can perform, these are both weak recommendations, clinicians can perform assisted reproductive treatment in women with deep endometriosis as it does not seem to increase the endometriosis recurrence per se. Any hormonal treatment or surgery can be offered to treat recurring symptoms in women with endometriosis. These are both weak recommendations. With this, we come to the end of our video. If you like the video, then please subscribe, like, comment, share, and press the bell icon. Thank you for watching. Goodbye.